So I want to thank the departments as well as Claire for allowing me to come and talk. Part of the pleasure of being an officer at CAP, which is not my day job. My day job is as an academic chair, and I'm running a department of 24 pathologists and a reference lab in a tertiary care academic hospital in Western Massachusetts. But I was asked to come to talk because one of the nice things about being president at CAP is I have the opportunity to come and talk in a lot of places. So I'm here. I've been at UCSF, Mount Sinai, Pittsburgh. I'm doing Yale next week. All the places where the movers and shakers in our field are, as we talk about, and I want to start discussions with everybody and have you continue the discussions about where we are as a field and where we're going. So I'm going to run through a number of things about advancing and securing our future. I was on the Board of Governors for CAP for 6 years. In the last 2 years I was there, I was chaired of the Council on Government Professional Affairs, which meant that we were heavily involved in everything going on inside DC. And it's very important for people to understand just the way organizations in medicine work. CAP is a 501c6. It's the only pathology group organization that's a 501c6. Everyone else is a C3. Sounds legalese, and it's exactly what it is. The difference is that a C6 can lobby, a C3 cannot. So what that means is, as we look at the panoply of pathology organizations out there, we all need to work together. But as things get involved with DC, it's the CAP that actually has the lobbyists and has the connections inside DC. So that's why we actually have a Path Pack, which I do contribute to, and I encourage people to be members of CAP and be members of the Path Pack because it's the only way our voice is going to be heard at all. So let me sort of run through a few things here. This is a picture of a corner of our building. If this were in a slightly different system, that would actually be a video that would sort of pan through, which if you were at USCAP a year or two ago, you saw talking about what we were talking about, the way we're approaching diagnostics, as we call it, in my hospital in Western Mass. So let me tell you just a little bit about Bay State so you have an understanding where I come from. We are not Boston. We're in part of the Massachusetts that's not Boston. So we're in the earthy, crunchy granola part of Western Mass, closer to Hartford, Connecticut than we are to Boston. Bay State is a $1.8 billion health system of 4 or 5 hospitals. 1/3 of that is an insurance corporation called Health New England, which we wholly own. And as I've had a discussion with a number of the leaders here, when you are the payer and the dollars are going from the left pocket to the right pocket, it's a different set of discussions as to how you support pathology and laboratory activities, as opposed to when you're talking with a third party such as Blue Cross Blue Shield. It's important that somebody know the flow of dollars. It doesn't have to be everybody, but somebody needs to understand the sources and uses of cash and how they come on in through an organization and what actually has currency in the organization. So in my group, I actually have one pathologist who's a dermatopathologist 60% of the time, and 40% he's a billing pathologist. So we are, I call it an academic private practice hybrid. We're affiliated with Tufts, so I'm a professor at Tufts, but our residency program is completely separate, so we have 4 residents per year. Again, 22 pathologists in the group, and a good-sized reference lab that competes head-to-head with Fortune 500 companies, and we own the left-hand side of the state, they got the right-hand side of the state. And for us, we actually changed the name of our department a number of years ago to Pathology, Diagnostic Medicine Services. So it's anatomic, clinical, molecular, cytogenetics, genetics in one department, which for us is a tactical move in competing in the Northeast U.S., which has a lot of split departments, and I know you're split here. But what it allows us to do is to go out and provide diagnostic services regardless of which door it's going to come in. And what it also allows us to do is actually have a significant involvement with radiology, which is another diagnostic service that we work very closely with. So that's how we've been approaching our life in Massachusetts. It's worthwhile just pointing out, I've got 7 years of experience with Romney Care. And if anyone wants to sit and have a chat about Romneycare versus Obamacare, some of you heard the quip about, I think the only difference is whether you watch MSNBC or Fox. But to a certain extent, it's going to be spreading elsewhere. We can have a discussion about the appropriateness of the political side. We can talk about whatever you want afterwards. For us, it's been a reality for 7 years, and we've gotten bigger, and we're growing. So I'll leave it at that. So let's talk a little bit about what's going on in the world. As you can see on the slide, healthcare is mainstream. How health is being paid for is mainstream. It is on the front page of the news. You're hearing people talking about terms from diagnostics to genetics to genes to drugs in common parlance that you never saw before. Well, the stuff that we do every day is not unusual to people who 20 years ago would not have known what a diagnostic test was. What they don't know now is our role in the system. And one thing I'm going to encourage everybody to do is to be sure that you do what you can to explain how you fit into the healthcare system. And as some of you have heard, my belief about where we sit in the healthcare system is we are that interface between science and medicine. Something comes in the front door, we're doing something scientific to it, we're making a clinical interpretation, and we're getting that out to the people who are going to act on it. That's for anatomic, that's for clinical path, that's for cytopath, that's actually for radiology as well. And we're the ones who can understand the science as well as the clinical side. And if we forget the clinical side, if we forget the patient, then we're purely technical. And if you want to be purely technical, then you're in a commodity market. And a commodity, by definition, is something that is differentiated only on price. You don't want to be in a commodity market. And the way to differentiate yourself is by by the professional bit you put on top of the technical piece. And this is where we're going to have to continue to refine and define the terms and define our role in this. And as I was having a discussion with the molecular folks earlier today on the sequencing, 6 billion letters, here you go. That's a technical achievement. What to do with it, what it means, how it fits in, is a synthetic function that somebody's going to play to put that all into a clinical setting. And that's, in part, where we fit. Everything you're seeing up here, why healthcare may be finally ready for big data. This is on the front page of the news every day. The Wall Street Journal had an article 2 days ago about the Apple Iwatch and how they wanted to have all these medical sensors in it, but they couldn't find it. I guess apparently they couldn't find them reliable enough to put it in the watch. Well, those of us on the CP side of the equation especially are not surprised at that. Just because something spits out a number and has a decimal point in it doesn't mean it's accurate. But somebody can sell a sensor that'll spit out some number with a decimal point. Apple's learning what we're seeing. So individualized care, personalized care, precision medicine, personalized health care, whatever term you want to use, and there's pluses and minuses to all those, we're part of it. We're the foundation of it. So what we're seeing in this country is there are clearly challenges and opportunities given the evolving healthcare landscape. And the key drivers are demographics, care models, emerging technologies, and economics. The demographics, I think the figure is 8,000 people a day are turning 65. If you plot your age, the number of tests you get versus age, the older you get, the more tests you get. Once you hit 65, it goes up pretty sharply. So if we do nothing as a society except get older, if we have the exact same number of people and we just get older day to day to day, you get busier. We don't need to have all these babies to have all the more volume. If we have babies, we will have more volume as well. But just getting older gets us busier. There's always going to be stuff for us to do. The question is, how are we going to do it, and what is the structure we're going to be involved in there? People are living longer with chronic conditions. When I was in medical school, which would have been in the mid-'80s, and if Chuck Murray is here, I'll point him out as a classmate of mine at Duke. And if you were class 4 for an NYHA heart failure, that was a 18 to 24-month death sentence. Now, that's a 20-year management problem. So what has happened to that person who is now living 18 and a half more years? He's getting a lot more tests, he's getting a lot more drugs, he's getting a lot more doctor visits, and he's not working more in the system to contribute. Costs are going up. People are living longer. There's an old line about smokers die of their first illness, non-smokers die of their second, third, or fourth. So if we stop smoking, people live longer and it costs the system. Not sure the numbers are all right. But the point is that if somebody is no longer alive, they're not using resources. As they live longer, they use more resources. We should not be surprised that the utilization of healthcare is going up, costs are going up, and we're getting busier. And as I've told some of you guys earlier today, as Romney Care rolled out in Massachusetts, we got busier. All the people who weren't getting testing, guess what? They're getting testing. And all the people who I wasn't getting paid anything for, I get paid something for. So as people live longer, they get more tests, they get more health care. There's new care models. Nobody knows what an accountable care organization is. There's a lot of N=1 for ACOs. But I would think of them as coordinated care more than accountable care. Accountable care sort of says somebody actually is responsible. But it's really more around coordination and coordination of care. There are emerging technologies, and we know that absolutely. You know, you can't open the paper without hearing about the $1,000 genome that I don't know if I've ever seen. But somebody out there thinks it's real. And economics, the move from pay for service, pay per click to value. And in a value model, if you can't show your value, you're going to be in trouble. As I was telling the residents earlier today, you need to figure out what you're getting paid for and what the person who's paying you thinks they're getting. Not what you think you're doing to get paid, but the person or the group that's paying you, what they think they're paying you for, and you need to fill that role, not necessarily the role you think you're. It's a different question. You need to understand what you're getting paid to do. There are tremendous opportunities for all of us in pathology, in all parts of pathology, to become directly involved in healthcare delivery. One of the other big changes that's part of this, healthcare reform with far more primary care is leading to far more nurse practitioners and PAs who do not have the experience, who know a lot but not everything, who have markedly unusual ordering practices. And as you get more NPs and PAs out there working side by side of the primary care docs, you're going to get stuff coming through that you can't really figure out why they ordered those things. One of your roles in the system is to try to coordinate the diagnostics, to make it more intelligent, to make it more appropriate. That's part of what we do right now. But as we end up with lesser trained providers, more patients, decreasing dollars, increasing regulation, we got a dance here we have to be very careful about. So CAP is working on your behalf. Again, CAP is a 501c6 organization. Anybody who's a board-certified pathologist is eligible to be a member. There are career resources online. There's opportunities for residents to get involved, and I'm sure Claire would be happy to talk to any of you about that. A couple of you have already spoke to me that you're on CAP committees, and I encourage all of you to consider your role on CAP committees. There's no better way to meet pathologists from around the country who understand what you do. I'm happy to talk to anybody about being on a CAP committee. If you want to apply, you have to apply online. We're only going to be looking at the ones who apply online, but that is available, I think, through the end of the month, I think it is. So there are a lot of opportunities for members. One of the opportunities, by the way, for members is there's a thing called CAP Connect, which I'll talk about a little bit at the end. We're going to continue this discussion, for any of you who want to, on CAP Connect on the online forum. And so when you go on After this discussion, if you go on and post an ongoing QA, you post a question, I'll get an email that somebody had just put something in there. In due course, I'll go on and respond, and we'll have this ongoing discussion. You'll reference this talk, and it's going to be an ongoing discussion section with which you're all welcome to participate in. Julie will be able to give you some comments on that at the end, perhaps. And Julie, do you have a sheet for them? Okay, so we'll get a sheet out so it shows you how to access that after the talk. Policy and advocacy. You're the only one who understands what you do. And by you, I mean all pathologies. We can't expect somebody who in Washington, D.C., who's writing rules and regulations that we're going to live by, and yes, this will come up in our discussions around the LDTs. We can't expect them to understand where we are in these things. So we need to be sure that we are involved with the rule makers, the lawmakers, to help them understand why it is we feel the way we do about where regulation is appropriate and how it should be in place. None of us are saying there should be no regulation. What we're talking about is there needs to be appropriate regulation. We are working closely with other groups such as the Association of Pathology Chairs. We've got an alliance, a training alliance with ASCO and with AMP, a few of these other groups. As we're starting to get all of organized pathology to start coordinating our messages so that we understand, so we can convey to the powers that are going to be setting the rules where we fit in. There are also opportunities on the CAP website for new learning opportunities in genomics and informatics, and some clinical practice guidelines as well. I think there's some examples of those in the back. So here are some numbers. There's roughly 18,000 members for CAP. There's been strong growth among pathologists in practice 10 years or less. There's a newly launched New in Practice for pathologists who are just coming out. And increasing amount of resources by and for practicing seasoned pathologists. And there's becoming less and less of a difference between the academic pathologists and the private practice pathologists. They're both facing the exact same squeezes. And that's why we're starting to find ourselves coming much closer together in our overlap for where we want the field to be. And you'll see that recently CAP has a new logo. You can see it in the lower corner there. I'm happy to discuss the logo. We can have a discussion as to what it is. Some people think it's a microarray. Some people think it's a peripheral smear. Some people, some of the older crew tries to figure out where the Erlenmeyer flask is, and the younger crew trying to figure out what an Erlenmeyer flask was. So one of the choices we have on the website is for new in practice pathologists. It's a life preserver, giving relocation management and some interpersonal skill assessment, performance assessment, etc. These are all available on the CAP website. I'll let you go there and take a look at those at your leisure. And residents, always vital. There's a CAP residence form, and I think you probably recognize, is that you there? And this was the 2014 to 2016 residence form executive committee. You can see Claire and there's Claire and the lady in red who are the only ones that aren't in something dark. Some people just stand out. So the residents, I encourage you to get involved with CAP. It's going to be part of your life as long as you're a professional. So what's going on in the current healthcare policy landscape? This triple aim of the Affordable Care Act talks about better health for the population, better health for individuals, and lower cost. They want all three, not just one. This is the push behind the reforming the payment system. And I want to take one comment, make a little political statement here. Do not be fooled that this is a Republican versus Democratic argument. This is not a Fox versus NBC argument. If you look at the last 15 years or so of healthcare legislation, the foundation of what we're talking about today was put in under the Bush administration, and the implementation was under the Obama administration. The rule of thumb when watching the talking heads on TV is don't listen to what they say, look at what they do. They will all say the other guy's wrong and I'm right. But if you look at what they're doing, they're pushing in the same direction. All the stuff around bundled care, all the stuff around Pqrs and pay for performance was put in place under the Bush administration. Obama came on in and put in the payer side of that. And by the way, it was put in place by a Republican Massachusetts governor who ran against him and kind of forgot about what he did. That's another discussion. This is not a one-sided party discussion. And I don't think people should be so foolish as to think that if you vote for this candidate, healthcare is going to revert to the way it was, or you vote for that candidate, it's going to revert to the good old days. This train has left the station. And the sooner I think we start getting away from the arguments about which party did what, and face the reality of what we're dealing with, we're better off we'll be. That was my own personal belief on a few things, and it's probably not CAP official policy. We've got a system right now which rewards pay per click. And doctors and providers and nurses are bright boys and girls who know how to, gee, if I click this 3 times, I get paid a lot more than if I click this thing once. We're shifting to a pay for value instead of pay for by per click. And you're going to see more things put in place to drive the value side of the equation. Is this going to be a capitated care model where somebody gives you $2,000 to take care of a woman for an entire gestation? Well, that's actually in place already in many parts of the country. Why wouldn't that get spread to other disorders? I think MD Anderson, Cleveland Clinic, some of these places have done things with major companies such as Walmart, I think is one in particular, where they're allowing their people to go to some of these places that you thought are more expensive for a capitated rate. Geisinger is doing that. Their proven care model. The idea of, come on in here, and if you stay twice as long, I make twice as much, is going to disappear. So CAP thinks about this as our now and future policy agenda. And I want to give you a high-level overview as to what we mean by the now and future. We got to work for now, but we got to plan for the future. So the goals are to mitigate cuts to pathology payments, ensure that pathologists can comply with CMS value-based payment models. And by the way, one of the problems we have with things that are coming out of Washington is they're usually set for primary care or medicine or surgery, and they don't really make sense for the way we practice. Just look at meaningful use. It's up to us to try to explain why we operate the way we did. I can tell you that one of the OIG interviewers interviewed a doc in my department trying to figure out how pathology fit in. And his comment to this GI pathologist in my group was, well, how many times a day should a primary care doctor order an 88305? Just if those of you who aren't familiar, 88305 is the level 4 surge path code that fits into nationwide about 80% of what surge path does. And for somebody to think that a primary care doc is going to order the 88305 points out, there's a whole bunch of things wrong with that. And we actually don't want the primary care doc ordering the 88305. It just shows a complete misunderstanding of the process. But we are different. We've got to explain to them why we're different. Another part of our agenda is to secure new payments for pathologists. There are going to be new revenue streams that are coming up, and we need to be sure we have access to them. Ensure a level playing field against unfair competition, and protect our scope of practice. Protect funding for graduate medical education. This would be a completely different place without a residency program. I know my operation would be a completely different place without a residency program. And guess what? A few more years after not having a residency program, we're going to have a tremendous shortage of pathologists. But we can have an interesting discussion about whether there's an excess of shortage of pathologists. I'll tell you my own perspective is that there's a mismatch. I can't find what I need, and people tell me they can't find a job. They're both true. We want to sustain a favorable laboratory regulatory environment. Not eliminate, but sustain it. CLIA is in its most recent incarnation, is from 1988. There was a CLIA 67 before that. CLIA is very prescriptive. CLIA doesn't have anything there about genetics. We have to be careful on opening CLIA because of what might happen once you open it. But it needs to be modernized. This is fundamental to the whole FDA question. As the FDA is looking at LDTs and how they want to regulate those, CAP a few years ago foresaw this coming up and put in place a proposal to update LDTs. And the proposal basically, in a nutshell, said there should be 3 levels. Very simple things at the low level, very complex things at the high level, and a medium level. And the amount of regulatory involvement in each of those would vary. And it would be tied in with perhaps your accreditation inspection, perhaps as you do testing, you'd have to send some information in somewhere, depending on the level of the testing. And this would work as part of your accreditation process. So as you develop LDTs, you'd have somebody coming on in or somehow looking at your work to independently verify or validate what you had done. What FDA in essence did was they changed the definitions so that the vast majority of things fell into the most severe category, which is why they think it's going to take 20 years to implement. And when I was talking with a major reference laboratory south and slightly east of here, they figured this was going to cost them somewhere in the ballpark of $200 or $300 million to comply with the FDA guidelines for LDTs. I'm not even sure you guys have an estimate as to how much it would cost you to comply. If we find LDTs being turned into the analog or the equivalent of patent-protected drugs, which is kind of what I'm afraid is the feeling there, everything's going to change for the way we practice. And this is not an AP or CP only thing. Most of your IHCs are LDTs. So we need to be sure we are working with the FDA to get this regulation logical, fair, and legitimate. There are groups that are challenging whether the FDA has the authority. I'm not sure we want to get into a my lawyer is more expensive than your lawyer kind of argument. Because one reading of CLIA says that CMS has the authority, but CMS apparently doesn't want to do it. FDA is saying they're entitled to do this because of the Medical Devices Act of 1976. They just haven't started it, which then says, oh, so you haven't been paying attention to this for 40 years? And now you want to start? Why have you not been doing your job for the last 40 years? I mean, there's some interesting conflicts in the logic. But we have to get this thing right with the FDA. So CAP is engaging with the FDA in trying to come up with a rational process. Other groups are saying, filing lawsuits to say they don't have the authority to throw it out. Our view basically has been appropriate regulation is the right thing to do. So that's the process we're taking. We are engaging directly with the FDA. We were also conducting socioeconomic research to inform our public policy agenda. If you have a chance, every May there's a policy meeting in Washington, D.C. There's some cards in the back for that. Policy meeting is a spectacular meeting, especially if you're a policy wonk or just enjoy the camaraderie in Washington, D.C. But you'll hear from Don Burrick will be talking there. And there's another well-known name that's is going to be talking. I'm blanking on who it is. We have some major speakers there coming from the Washington, D.C. inside environment to tell us what's going on inside Washington, D.C., and it gives you a chance to go meet with your representative from Congress. And by the way, if you haven't met with your representative from Congress, I strongly encourage you to do so. So when you go and talk to that person and realize that the person who has the strongest influence over them knows nothing about what you do or how you fit into the system, you will suddenly begin to wonder how how the sausage actually gets made in Washington, D.C. So I encourage you to get involved with your politicians, They're nice people. They're actually generally good-meaning people, they're well-meaning people. They're good people. They just don't know. They just don't know, and we need to explain it to them. And CAP is also mobilizing CAP members for grassroots action. So I'm not sure what you have here as far as a state society. I should know that. Some states have bigger societies than others. If there is an active state society, I encourage you to be involved with that as well. So mitigating payment cuts. When the professional fee schedule came out for 2015, immunohistochemistry got a bit of a bath. There are a couple issues going on here. It would have been worse, I can tell you that for sure, without us being involved. But we had some problems with the G codes from last year. CMS accepted a new CPT code to more accurately pay for IHCs. It's not as good as it was 2 years ago, but it's better than it was 1 year ago. And CAP is engaging right now with CAP to submit more comments on the lower add-on costs. The way the process works for CPT codes, and it's important to understand this part, CPT is owned by AMA. And when a code is determined, a group of people gets together and looks at the work value in it, the various components of the work value, to come up with a relative work value. And that gets voted on in aggregate with everything else. And then the work value units are fit into, by conversion factor, into the total dollars that are available in that area. So CAP does not write the CPT codes. We are on the RBRVS Utilization Committee, the RUC. We are on that committee. Members of our Economic Affairs Committee in the Washington, D.C. office, pathologists, are part of that committee, and they are the ones who are helping to work out the value for the 88305, the 88307, all the Part B codes. CMS initiated a new G code for prostate biopsies. Prostate biopsies, I think, have caused us a challenge in the field as labs went to build up their own volume, and labs were put in place by in-office labs were put in place by certain for-profit ventures and generated a tremendous amount of money. I seem to recall, and I may not be accurate on this, that the 88305 is now the 7th largest by volume billing code in all of medicine. Does that make any sense at all? Try to explain to a doc why if we get something in 12 jars, we get 12 extra dollars. And when the urologists realized that they can actually make more from the technical component, the 88305 times 12, than they got for doing the procedure, all of a sudden you realize the dollars are out of whack. They recognized it. They put in place the processes to maximize the value, as good capitalists do. And we're all seeing the consequences. So there's a new G code in right now for prostate biopsies, and I'll tell you this, CMS thinks that's overvalued. So they're going to try and reduce that one. So CMS wants to revalue the prostate G code. So when CMS gets the final RUC recommendations, they will consider it. Fish testing. We led an effort to protect the payment for fish services. It resulted in CMS adopting new CPT codes. And we used our position on the RUC to mitigate payment reductions for services that they targeted as overvalued. One thing CMS has done in the last couple of years is they've gone back to their original valuations, looked at things that cost this much money years ago and now are costing this much money. So something is overvalued from their perspective, and they're going after that. It's sort of like the game of whack-a-mole. You know? When a mole pops up here, something whacks it there, and then the revenue pops up over here, and they whack it over there. This is when people start overusing a service, there are ways to approach that. One is to reduce the reimbursement or change the rules on it. That's essentially what's been going on. So we've advocated for revaluations to accurately account for the cost of services provided. But as an academic, as a chair of a department who deals with RVUs, I can tell you they're not relative. Somebody in derm path or GI path is going to have more RVUs in it for a certain number of hours than somebody doing breast and colon, breast and prostate. It's just the way the system works. We are one of the only fields that has our unit of service as the specimen and not the patient. And on the CP side, a lot of this is all bundled into the clinical laboratory fee schedule years ago, which had never been internally readjusted. Well, now CMS is saying, oh, we're going to go back and readjust that code. So if a sodium were 5 times what a potassium is, then I don't know exactly what the ratio is. If that's what it was 20 years ago, it's still the same ratio right now. They just they lowered the whole thing by percentages at a time. But now they're going to go back, they're saying they're going to go back and reassess that testing, that pricing. So these are all challenges we're going to be facing. There are payment opportunities. Pqrs Pathologies has 3 new Pqrs measures, one on lung cancer reporting for biopsy and cytology specimens, one for resection specimens, and one on melanoma reporting. The funny thing about the Pqrs for pathologists is most pathologists I know are complaining about it. I think the average reimbursement is about $300-400 per pathologist. But guess what? Pathology has the highest participation of all medical specialties in Pqrs. So we are getting something out of it. Now let's talk a little bit about the laboratory regulatory environment. So on September 30th, the FDA released its oversight guidance document. And as you know, CAP has been seen as a leader in the field and a critical stakeholder for designing an appropriate framework for oversight that ensures patient safety while fostering innovation. And I want to stress the patient safety thing. We tend to talk about quality, we tend to talk about regulations. But the reasons we're focused on quality and regulations are for patient safety. I think we need to remind people about that, because if we forget about the patient, we become technical. The only reason we're concerned about quality, reproducibility, reliability is because of patient safety. So CAP testified during an FDA public workshop back in January. You may know Dr. George Quast, Dr. Volk, and Dr. Gail Vance, who were there and presented our cases to the FDA. We stressed that pathologist participation in Ldt oversight is critical. We have the needed expertise for it, and we have a long history of being responsible for the overall operation and administration of the laboratory. The formal comments of the FDA are available on the CAP website. If you look at the cap.org/get involved or advocacy, you'll find it there. I don't know if we have the URL up there for that, but the formal comments are available. And the CAP recommendations would also harmonize requirements under CLIA. Now remember, CLIA was written in '88 and has a strong role for CMS. FDA is a different bucket. And CMS seems to be wrapped up with reimbursement issues. And there's you can think of it as there may be a bit of a turf war going on as to who gets to control this area. We want to be careful about not being on the wrong side of that argument. In our opinion, the FDA draft guidance would stifle medical innovation, affect patient access, and put a tremendous administrative burden on the laboratories. Again, $200-300 million for one good-sized laboratory in the Mountain States. We called on FDA to change its definition of an LDT, continue their enforcement discretion. We're not telling the FDA to back away completely. We're talking about, let's talk about how to implement this correctly. And limit the breadth of the high-risk category so it does not include all companion diagnostics. The way the FDA defined this included all companion diagnostics in the high risk, which the best way to think about that is the way they want to approach it would turn it into a drug. So every time you changed anything in the assay, you'd have to revalidate. Just think about how difficult that would be. The existing FDA medical classification categories include many well-established validated LDTs and subjects those to a tougher regulatory environment. We estimate that at least 1,000 of common LDTs to be classified as companion diagnostics under the definition the FDA is using right now. At least 1,000. And I'll bet you that includes a lot of what you're doing. So we believe the LDTs should be classified based on patient risk, the laboratory's claims for the test, and potential for harm to patients in instances of incorrect or misinterpreted tests. It depends on what the test is for. If you look at a companion diagnostic for the V600E mutation, Zelboraf, it actually specifies you have to do the test on a Cobas 4800. So if you do it on a slightly different or newer or the next generation, you're using that off-label. And there are certain payers who want to pay for the FDA-approved model only. So would a reference lab have to have one of every manufacturer's devices, depending upon which drug was being ordered? And how are we supposed to know which drug is being ordered in order to get reimbursed properly? Just think about the complexity involved in this. Most of us tend to have harmonized on one group of equipment, perhaps across the system. You don't want to have multiple devices of the same thing, let alone have people trained to run them all. But could you imagine actually sorting out the test based on which drug the patient might get as to which platform to run it on? So our long-standing principles for LDT oversight are to assure quality laboratory testing for patients, allow for innovation, and prevent undue administrative regulatory burdens. We're going to continue to be engaged with the agency. That's the fundamental issue. We've had a long discussion about it. We're not going to fight everything on this. We're going to work with them to make it make sense. CAP has heard from the members and that has written the FDA guidance would impact their ability to provide appropriate and critical testing for the patients. And our model for this was presented to the FDA in 2009. They've had this for a while. They just reinterpreted a few things. Far too many things. But our belief has not been changed that the fundamental role of LDTs belongs in the practice of medicine in the pathology laboratory. And we'd like to coordinate our efforts with FDA as well as CMS to reduce regulatory burdens on pathologists while it's ensuring accurate access to patients access for patients to quality laboratory tests. Let's talk a little bit about securing new payments for pathologists. A Medicare contractor, Palmetto, which oversees North Carolina, South Carolina, Virginia, and West Virginia, issued they call a final local coverage determination, a final LCD on special stains. This came out a little while ago. We've pretty much opposed that. And we called on Palmetto to withdraw it. There's another Medicare contractor called Noridian, which is yours, I understand. And now it's not proposing the same LCD. And if you look through this LCD, and we can get you copies of the actual local coverage determination, this is in essence a small group of individuals, maybe as few as one, who think this is the right way to practice. And they talk about whether, for example, you should order H. pylori stains before you've actually looked at the slide. And you can make an argument about whether you should be able to tell whether there's H. pylori there from looking for some sort of morphologic changes on the biopsy and then go back and get the H. pylori if needed. Or you may take an approach that, gee, the docs want the results as fast as possible, and since we have a prevalence of 70% or whatever in our area here, it makes sense for me to order this in all the ones so I can get that result out a day sooner. Which is right? Well, this should be an individual call. It should depend upon your local practice variation, your local practice expectations, and your local practice values for how common H. pylori is in your population. If it's 100%, you don't need to do the testing. But the point is, when somebody starts taking their own perspective on how to practice and says this is all we're going to pay for, it starts causing major problems. So we are actively opposing the Noridian proposal. It is the same as the one from Palmetto. And yes, the medical director at Palmetto is a pathologist. So CMS advocates with CMS and private payers to secure coverage of molecular and pathology services. It's an interesting question as to why the molecular testing did not end up on the professional fee schedule and ended up on the clinical laboratory fee schedule. We have to have that discussion offline with anybody. But in essence, it comes down to the fact that the clinical laboratory fee schedule had never been changed. And if you're getting paid $1,000 for a test that in 5 years maybe you're only getting paid $3 for, you probably want to lock in that $1,000 as long as you can. So we need to find a way to get paid for molecular diagnostics. I'm sure you guys are taking a bit of a bath on your molecular testing. As I've talked to a few of you guys, I have completely different arguments when I'm talking to Blue Cross Blue Shield as I do if I'm talking to other payers because of their perspectives on the value of the molecular testing. Some of us think molecular testing is not a question, it's a necessity. EHR meaningful use. CAP secured for pathologists full relief of Medicare penalties under the Meaningful Use Program in 2015, and we're working to extend that. I'm not sure if any of you here actually qualified for meaningful use. Jim, do you know if you guys did that? You did here? The way law was written was very difficult for many pathologists to qualify. Most LISs, laboratory information systems, and AP information systems were not certified. So if you work in Cerner or you work in Sunquest, you may not, depending on which version you had, you may not be able to qualify because the system had to be qualified. There's a recurring thing around SGR, Sustainable Growth Rate. And this goes back to the Balanced Budget Act of '97. This is what comes up every year about the doc fix and are we going to get a 30% pay cut on a given January 1st or July 1st. So in 2014, we secured some legislative language in the SGR repeal bill. And legislation would grant authority to establish alternative qualities and measures. Pathologists could meet rules for those quality initiatives. And we continue to engage with Congress to repeal the flawed SGR formula. The SGR formula was written at a time when they said that inflation for healthcare would be the same as for a market basket of goods in the economy. Well, now there's a 30% difference. Every 6 months to a year to 18 months, Congress has put off the day of reckoning. But it's always been just kicking the can down the road. There is a permanent repeal of the SGR is still elusive just due to the cost. I think it's up to around $300 billion right now to fix that. House GOP passed the bill with ACA repeal as a pay for. Congress must act again by March of 2015, and odds are you're going to see another patch, April 1st. So this may sound like just preaching to the choir about getting involved. Get involved. Nobody understands what you're doing other than the people in this room and other pathologists. You need to be able to explain what it is that you do and how you do and how you fit in. And I encourage the residents especially, but everybody, to have in your head the elevator pitch story. The elevator pitch is the idea that they teach in business school, and that is you get into an elevator and there's somebody with you in the elevator while you're going up 10 floors. And this is an important person, and it's very important for you to get the time with them when they're locked in this tiny little room with you. So the elevator pitch is your 25-second spiel. Who you are, what you do, and why it's important to them. And for the residents, have your elevator pitch when you're going for a job interview. It doesn't need to be, it can't be a 5-minute discussion. It needs to be 25 to 30 seconds. Because if you don't get it by then, you've lost them. Residents need to have that in their own mind as they're looking for their positions. But we all, in our own way, need to have an understanding, a concise terminology that you basically have pretty well down by rote. What you do and why you are worth what you're doing. A few other points on our now and future policy agenda. The Federal and State Affairs Committee and the Council of Government Professional Affairs get involved in state and legislative regulatory issues. So the model ACO legislation has been enacted in New Jersey, Tennessee, and Ohio. There's an interesting story about this one. I was talking with our legislator in the State House in Boston about the Massachusetts state law, and they weren't going to write in there anything specific for any field. So we wanted them to say pathologists have to do this, and they said we're not going to say any group has this bit of turf. So we pointed to the Code of Federal Regulations. We said there's a 40-year history in there of a clear medical director. And we had them put in that the ACO had to have a utilization committee. Strongly, they didn't say have to. It has to have a utilization committee, and strongly encourage them to have, specifically in the legislation, strongly encourage to have a clear medical director beyond that utilization committee. And the reason to have the clear medical director and utilization committee was a very interesting question put to me by the legislator. He said, if I give the hospital $1 million to run the laboratory, that administrator is incentivized to run no tests at all. Who's looking out for the patient? My point to him was, we have a clear medical director who's a physician, happens to be a pathologist usually, but not always. We have a physician who has a fiduciary responsibility to the patient. And that's why they need to be in there. So somebody is representing the patient in the utilization committee, and that's the pathologist. So we get involved in CAP with scope of practice, lab professionals, pharmacists, genetic counselors, PhDs. It's an interesting discussion about PhDs and billing. As to whether they should be able to bill independently. Be happy to go over that with anybody separately. It's a complex question. The biggest problem, by the way, for the PhDs is there's no state licensure. And so you can't really say that because you have a PhD, you are qualified for molecular testing if your PhD was in art history. There is a state-by-state licensure system, which the way it is in 50 states is limited to MDs and DOs. That's where the whole thing fell apart. I mean, there's no state-by-state system for PhDs. But we can work out a system where PhDs work with pathologists and bill with the pathologist. They take advantage of the MD necessity of the states, the MD or DO. Some other issues that are important for us in different parts of the country, anti-markup legislation. This all comes down to whether you do a test for a doc and he can charge the patient more than he bought it from you for. And we've had the ACO, our model ACO legislation endorsed in a few more states. I encourage you to look at the policy meeting. George Wool was the other name I was looking for. He's going to be a keynote speaker, and as well as Don Berwick. Don Berwick is the guy who led the Institute for Healthcare Improvement. Everybody who I saw told me, oh, he's running for governor of Massachusetts, which I always heard far more of outside of Massachusetts than inside Massachusetts. And by the way, just for grins, the new governor of Massachusetts used to run Harvard Pilgrim, which is one of the insurance plans associated with Harvard. He's not a physician, he's a hospital administrator. And in true Massachusetts tradition, he is a Republican, and probably the only Republican elected in the state. But Massachusetts has a long history of old-style, if you will, pro-choice Republicans, which the rest of the country doesn't always seem to understand. So we are partnering with to advance the specialty, improve patient care, between the APC, API, ASCO, AMP, ASC. We were all talking together. We had a little over a year ago, we had a Path Societies meeting in Washington, D.C., which we convened. Fascinating part about it, there were 26 individuals representing 34 pathology societies. Why do we have 34 pathology societies? But everybody had a viewpoint, and some people, because if you look at the math of having 24 of these and 36 of those, some people had 2 viewpoints. But we have small groups. We need to coordinate our activities. CAP is the largest. ASCP has the most members. Majority of the members are med techs. CAP is physicians. It's board-certified physicians. It is a large organization. CAP is actually, by some measures, the second largest medical society in the United States by budget, about 20% smaller than the AMA. It's a large organization, not because of all the pathologists who are members. That's only a fraction of it. It's because of all the PT. It's because of all the regulatory stuff. it's because of the accreditation, it's because of the education, all the other parts, which is exactly what we need to have in place for the FDA LDT process. That's why we should be policing ourselves as we've been doing since 1961. And for those of you, I've heard people say that you know, CAPS took this position and I disagree with them, so I don't want to be a member next year. Let me just tell you that if there's 10, 12, 15,000, you pick a number, paying members of CAP, and it's $390, $360 a year, you're talking about less than $4 million a year in revenue. The DC office alone is more than double that. CAP wouldn't be CAP without the accreditation, without the regulatory side, without the laboratory inspection side. And that's what we really need to be sure the FDA and CMS allow us to practice our field the way we feel we need to practice it. Jim, I'm not sure where you guys are on informatics training here. I assume you've do a fair bit of it. Since '77. So we have a commitment to informatics training in pathology. And actually there's a thing called Pathology and Informatics Essentials for Residents. PEER, it's a collaborative joint product of APC, API, and CAP. And it helps prods assess unmet needs for pathology informatics training that is available online. My group in Bay State is one of the 14 that is alpha testing this year with our residents. You are as well? Okay, glad to hear it. And then I'll go on to the next slide. We have learning in lots of CAP learning used to be called education. The term now is learning. More than 300 courses on the CAP learning portal. And by the way, I understand the new CAP website is Mac compatible. Yeah, that's a long-running story, but it has to do with the fact that the CAP we've just finished a massive data infrastructure switch that is, when you realize that their CAP covers 20,000 laboratories in 100 countries, the security on it has to be phenomenal, because I'm going to have 8 different personas that I could be where I need to have access to and where not to, because I'm medical director of this lab, but I'm chairman of this and I'm on that committee. It's a phenomenally complex project, which they finally got majority of it done late last year. There'll be continued improvements in the website coming on soon. But there's a whole infrastructure replacement behind it as we replaced something like 38 to 40 disparate systems with one. AP3s, Advanced Practical Pathology Programs. There are a set of these online. This is a combination of online learning and live faculty-led workshops. But breast predictive factors, laboratory and medical director programs, fine needle aspiration, I believe, is another one. Take a look at those online. Lots of SAMs for those of you who get to enjoy SAMs. More than 80 of them are on there. A genomics curriculum. Practical genomics for practicing pathologists. Lots of webinars. Lots of webinars. And recently we launched the Molecular Oncology Tumor Board series with CAP and with ASCO and AMP. And that is hosted by ASCO. And so I've actually been quite impressed with ASCO. I actually joined their group this year and I'm going to start attending. Because ASCO, actually, they understand more about us than most others do. And we've got some evidence-based guidelines from groups such as ASCO, AMP, and ADASP collaborating with us. 7 guidelines with 11 of them in development, all part of our evidence-based clinical practice guidelines. A CDC grant recently to improve guideline adoption. So stay informed. We are increasingly using social media. I really want to encourage people to attend the policy meeting in D.C. in early May. Love to see you guys at the annual meeting in Nashville, the Gaylord Opryland, in October. And we're going to continue the conversation online. If you go on to community.cap.org, Julie's going to hand out something, I think. You're handing it out at the end, Julie, for how to get on there. I have to identify that you're at this talk. It'll put you in there. You ask a question, and then somebody's going to get in touch with me, and I'm going to respond to it. And we'll continue the discussion as long as people want to have discussions. There's a lot of things we can talk about. Anything appropriate, I'm happy to discuss. I'm happy to stick around for Q&A for a while. My next real obligation is tomorrow morning with the wife as we catch a flight down to California. But I'm happy to catch up and talk to you about really anything you guys want to talk about. We're at a point right now in the field where there's a tremendous inflection point that we're coming to, so where we're going to be. And I want to be very careful, especially with my cap hat on, that we find ourselves on the professional side and not the technical side. The technical stuff will change. The professional stuff is an adaptation continual. And I've stressed with a number of you about you don't want to be a microscopist, you want to be a diagnostician. Don't be defined by your tools. You should be using all available tools to get the appropriate answer, to translate the science into the medicine as only we can do. And if all we do is say, gee, the number is 26.4, and let them figure out what it means, then we've abdicated our role in the field.